My report would say anesthesia, propofol based given by anesthetist. I don't have anything to
So
do.
there was no anesthetic there.
That's fine, that's up to them, but I'm just pointing it out. But it's good you must write it. What I'm showing this for two reasons. One, you need to have all this information, indication. Okay. We have on our report वो भी शहरियार आ जाए तो मैं अपनी report डाल दें तो मैं आपको बता दूं. Now, if you read the report here, using previous pre-cut wire passed into the CBD, and somebody, this is the second attempt, so it doesn't say anywhere here that there is a procedure done before. Into the CBD, and cholangiogram showed mildly dilated CBD with filling defects and distal CBD stricture. Okay, so filling stones and CBD stricture. Dilated with Suhindra dilatation, and stent tried to pass but could not negotiate the stricture. Later, CRE ampuloplasty tried till 11 mm but failed to deploy 7 French stent. ठीक है, अब इसकी टेक्निकल चीज को छोड़ दें, सिर्फ लिखा जो जा रहा है ना वो समझ में नहीं आ रहा. What the hell do you mean? If you got a stricture, were you able to pass a guide wire? If you were able to pass a guide wire, then what was happening? It is not mentioned here that you passed a guide wire. You're trying to negotiate the stricture with what? What kind of wires did you use? For me to go back and do it next time, I need to know what did you do. So it doesn't tell me that. Later they do an ampuloplasty. What is an ampuloplasty? I don't know. I've never heard of it. Okay? Which means you don't know where you are and you're trying to dilate the ampulla. Okay? Try till 11 mm. I mean, bloody hell. But failed to, and then what happened after that we don't know. Then they try and deploy a 7 French stent on what? Where's the wire? So your report should have said that CBD stricture dilated, attempted passing a guide wire, failed or succeeded. Over the guide wire, tried Suhindra dilator, unable to pass through the stricture. Okay? And if that's so tight, then that's where you stop. No, but it doesn't stop here. Using pre-cut needles, stricture was cut.
How can you do that?
Now, how do you cut the stricture? I am not an expert, but I have two experts from overseas. I want to learn, how do you cut a stricture?
We don't learn from him.
This is something that is going to be a case report in the international literature for the first case. And using stone extraction balloon, a 10 mm stone retrieved under direct vision. You have a cholangiogram, you have no mention of wire, you don't know what is being dilated, you have ampuloplasty, which nobody has ever heard of, you've cut a stricture with needle knife, which has never been heard of, and then you take a stone out which is 10 mm. Here, with multiple filling defects, mildly dilated CBD, distal CBD stricture, how the hell did you take the stone out, which is 10 mm? So this is all rubbish, and that's what we would like you not to do. Be honest, stop. When you don't even know what an ampuloplasty is, why are you writing what the hell is it? Are you supposed to, this is lawsuit, man. This report will take you straight to the cleaners. If Waqar is called as an expert, Khalid is called an expert, or by any chance I'm called as an expert, I'm sorry, you're dead. Okay? So this guy should be banned from doing ERCP. He's taught some people, even in this room. So God bless them. Okay? So how not to write the report is where I started. I feel like sending it to one of the journals and saying, a great case from Pakistan.
Excuse me, sir. CRE ampuloplasty means spectroplasty.
I don't know. Ampuloplasty, I don't know what ampuloplasty is. CRE ampuloplasty, I don't know what it is.
कुछ वो designated terms होते हैं जो आप use करते हैं, आप अपनी तरफ से बेइज्जत नहीं करते इसमें. Ampuloplasty आप किसी international journal में या किसी उसमें लिखें, किसी जगह communicate करें, they wouldn't know what you mean.
यार आप स्ट्रक्चर को नीडल से काट रहे हैं, खुदा को माने यार.
Structure को कौन काटता है नीडल से आज तक?
मतलब
Have you ever done that?
now I needed the other report. वो कहाँ है? share, yeah. Okay, no problem. Maybe I don't know, how do I get to our reporting system? Okay, this is another one. I'm not purposely hidden where they're coming from because I don't care. Okay. This is fine. Conscious sedation, ASA level, great. Even better than us, to be honest. Consent was obtained from the patient after a detailed explanation regarding risk benefits. Excellent. Okay. So you need to put in all this information if you can. Pre-op diagnosis was recent pancreatitis, proximal CBD stricture on MRCP. Okay. Edematous ampulla, pancreatic stent deployed in view of pancreatic cannulation. Great. Okay. Only problem I have is proximal CBD stricture presenting with recurrent or recent acute pancreatitis. How it's difficult to explain. They have written the dose. Great. As per anesthetist. Okay. So it's perfect report in terms of reporting details, reason, everything is there. Ampulla ki description is important. I don't have my format, but this is what, almost this is what we do. So you need to write what the ampulla was. Was it normal? Was it in the diverticulum? Was it eccentric? Was it easy? Was it difficult? Was it post-sphincterotomy? Did it have a stent beforehand? All those things you need to write about the ampulla. Then after ampulla, you put pancreatic duct and CBD. Okay? Pancreatic duct, if you have not attempted to cannulate, put no attempts made to cannulate. If the patient has pancreatitis, at least you have not touched it. If you put the wire in, put just pancreatic duct cannulated once, wire passed, no dye injected. Okay, saves you. Also tells me that you are very good. CBD, what is the level of stricture? What is the CBD dilated or not? Is there a stricture? Are there stones? If there's a stricture, is it a distal stricture? Is it a proximal stricture? Is it involving both the ducts? The surgeons want to know how much CBD is above the stricture, because then the surgery changes. If it's involving both the ducts, surgery is totally different. Okay, so that's yeah, Doctor Sahab, that patient has come, I think. So it's important to do now whatever you have done. The example that I gave you, sorry. Whatever you have done as therapy, sphincterotomy done, needle knife done, stone extracted, how many stones, did you do an occlusion cholangiogram or not? Your duct was completely cleared, occlusion, my report says duct completely cleared, occlusion cholangiogram done to confirm clearance, period. I'm safe. Stent placed, what size of stent in terms of width and what diameter and in terms of length. 10 French tha, 7 French tha, single pigtail tha, double pigtail tha. Pancreatic stent था तो pancreatic stent था, CBD वाला तो नहीं डाला था, holes बना दिए थे. So you have to put all that, okay? Now the reason why I put this one here is selective CBD cannulation was attempted multiple times using sphincterotome. Other catheters with different wires, but wire was going into the PD. Double wire technique was used and still CBD could not be cannulated. Absolutely fine. Selectively, despite good engagement of cannula, likely due to single opening of pancreatic and biliary duct as visualized on MRCP. Precut was not attempted due to edematous ampulla. A small amount of dye injected which showed normal PD, a plastic stent of 7 French, 5 centimeter placed in pancreatic duct. Anything that's wrong here?
So, size of the stent.
Yeah, size of stent is 7 French, 5 centimeter is in, you're trying, this is prophylactic, trauma. It is possible if I give them point, maybe by mistake उन्होंने 5 French 7 की जगह 7 French 5 लिख दिया, but then अगर उन्होंने 7 यहाँ लिखा है तो 7 कहीं तो था, इतनी लंबी लेंथ डालने की ज़रूरत आमतौर पे नहीं होती. So the one thing that I wanted to see was that 7 French should not be used for prophylaxis. I mean, we have 5 only. Khalid was saying 3 or 4, and I think he's absolutely right. Short stents, thin stents is what so if you have 5 is the thinnest I generally have, so I use 5. Okay, pre-cut was not attempted due to edematous ampulla. The problem is that, okay, so they did not do all that. No complications here, which is great report. So all this information should go. Common hepatic duct, extra and intrahepatic bile duct, cystic duct. I don't put these in our forms because the more information and more columns you put, the more you have to fill unnecessarily. If you haven't seen the cystic duct and it's not what you're doing your ERCP for, why do you have to write? But अगर वो column में आ जाएगा तो फिर आपको लिखना पड़ता है. तो अगर आप print कराएंगे तो CBD, PD लिखें और उसके बाद आपने जो add करना है कर दे. That's what we do. This very difficult patient was told, is a professor in this university. She had 2 attempts. This is not just one. She was told that if we do needle knife, there is a 10% chance of perforation and complications may lead to death. Okay? Which I had a problem with. And this patient was done, this was alhamdulillah done in first pass, 5 minutes.
No, I'm glad they mentioned that and did not attempt.
And did not attempt. Well, I think that was
Actually, the doctor got scared. You were not here, but I'll show you this. 5% chance of colonic perforation due to polypectomy. You know the size of the polyp? Less than 1 centimeter. So I put institutes there to show you that these are the top institutes of this city. Okay? And we have a long way to go. Pakistani Endoscopy Society, Gastroenterology, it probably is just not even born. You know, that's where we are. So at least पढ़ो यार, complications देखो literature में क्या है, और अगर तुम्हारी 5% complication है तो खुदा के लिए बंद कर दो. Okay? Now, so that's what reporting is all about. Any questions on reporting? I showed you a unit pictures. I have some. Huh?
Show your report.
अब हमारी जो report यार है वो इसमें कोई मुझे अली कैसे endoscopy data बस एक मिनट ठहरो. Okay, got it. Right. So this is what our report says. So if we do it under GA, we would say GA because we don't give propofol here. Midazolam dose, Kins, antispasmodic use. We use xylocaine spray. Details of the patient. We have some information which is filled in by mostly juniors here. We like to know what the bilirubin alpha person recorded. So because it's a long list, it helps us. Access to papilla, accessed or not? If not accessed, why? Is there an obstruction? And then cannulation, whether we cannulated just bile duct or CBD. And did we actually, you can take out, you cannulated, did you pass wire or did you opacify? So both options are there on our report. Did you do a pre-cut? Yes or no. Stone removal? Yes or no. Stenting? Yes or no. Size, type, sphincterotomy? Yes or no. Sphincteroplasty? Yes or no. So all this goes there. And then you have this space where you can write any details you want to write. So most of the information actually goes in yes or no. And then endoscopy, whoever was doing it, assistant, and of course the date. Okay? This was all done, software, design, everything done by Shariar. And we do it here. We use this system here and in Patel Hospital and I think in other hospitals including my private practice as well. That's as far as the reporting was concerned. Okay? We showed you how not to, what you should not report. Be honest. Now post-op, after you've done ERCP, what do? We usually keep the patient NPO for 2 hours unless I have manipulated and I have very good reason or I am highly suspicious or expecting pancreatitis, in which case I'll keep the patient NPO for 4 hours until the pain. If she has no pain, if she has pain, then they remain NPO. They're admitted overnight, treated with Tremol, not IV Rizec, not Buscopan, because they don't work in pancreatitis. So give some painkillers, whether Kins, Tremol, or Ketorolac, whatever you like. And give IV fluids, that's very important. You would have already given rectal diclofenac and push fluids. And if you had pancreatic stents, you've done everything, you're still suspicious. Quite often patients after ERCP, if they've been constipated a little bit, they will have pain because they have wind trapped. So make sure that that's not the issue and the patient's not having pain, because MLAs will be high and significant percentage of patient does not tell you that it's pancreatitis, okay? If you have complications, patient has abdominal pain, you have to, obviously we discuss perforation, pancreatitis, rule that out, discuss with the family, admit the patient. Most patients settle down within 24 to 48 hours. We, as I said, give antibiotics to all our patients for 3 to 5 days, regardless of what we've done. In some patients where I suspect the bile is really bad, pussy, then I would give them IV antibiotics for 48 hours and then shift over to oral antibiotics. Okay? Post-op mein ye hota hai. I always follow up my ERCPs after a week, and that's to tell me that they had no problem. Okay.
Every patient post-ERCP should be admitted or no?
No. Our patients have not been admitted since I started doing ERCP in my unit way back in 1996. Only patients who have pain or we are worried about would be admitted. Otherwise, we used to keep them for 2 hours, 4 hours, and then send them home.
4 hours अगर कहीं staff के clinic से आप 4 hours तक तो कैसे?
क्लिनिक में तो हम करते ही नहीं ERCP ना.
Hospitals में वो doctors.
हॉस्पिटल में अगर आपके पास रिकवरी भी नहीं है तो ERCP मत करें.
हाँ मैंने प्रैक्टिस किया लेकिन वो होता ही था कि रिकवरी का फॉर्म तो शिफ्ट करते वार्ड में एक दिन तो
यार आगा खान में एक दिन पहले एडमिट करते हैं, एक दिन प्रोसीजर करते हैं, एक दिन बाद कम से कम रखते हैं. ठीक है.
मैं आपको जो पॉइंट्स वो कर देता हूँ. हमारे साथ एक कैंडिडेट से, हो सकता है आप में से कोई जानते भी हो, पेशावर से थे. उनने जापान में कोई कोर्स अटेंड किया था और वो वहाँ से आके कोलोनोस्कोपी तो आई डोंट थिंक इतने करते होंगे क्योंकि यहाँ पे कोर्स अटेंड किया था उन्होंने हमसे, हमारे साथ भी. लेकिन ही यूज्ड टू डू, उससे हमने पूछा तो कहते हैं कि मैं EMR प्राइवेट में करता हूँ. मैंने कहा उधर करते हो तुम? कहते हैं नहीं जी पेशावर में हॉस्पिटल में तो नहीं है, प्राइवेट में करता हूँ. अब EMR कैसे है कि मैं कल खालिद हसन साहब के साथ डिस्कस कर रहा था. आई वाज वन ऑफ द फर्स्ट वन इन UK टू स्टार्ट EMR इन 1995, जबकि हिरोहितो यामामोटो आया था वहाँ पे हमारे यूनिट में ही वाज वर्किंग. तो उस वक्त को UK में नहीं कर रहा था. लेकिन अभी भी 1-2 साल पहले आई हैड टू डू एन EMR ऑन अ प्राइवेट पेशेंट ऑफ माइन. तो उसको आई इंसिस्टेड दैट शी कम्स टू माई NHS हॉस्पिटल एंडोस्कोपी यूनिट. वहाँ पे मैंने किया क्योंकि इट वाज अ सेरेटेड एडिनोमा with low grade dysplasia and I had to take it out. I felt very uncomfortable doing it in a private hospital क्योंकि the staff was not the same, quality वो नहीं थी, theatre staff था, equipment was not the same, and I didn't feel comfortable. If any complication happened, I would not have the same backup as I would have in my normal. तो मैं इस पे हैरान हूँ कि जो लोग animals पे वो कर लेते हैं tissue पे EMR practice और वो फिर private में करते हैं. I think that says a lot.
That to answer your question, make it simple for you. अगर आपके पास facility नहीं है रिकवरी में रखने की, तो फिर आप उसको पेशेंट को एडमिट कर लें overnight. But you see, it's cost. Depending on where you're practicing. Where I'm practicing, it's 20,000 rupees just to spend a night. 20, and it can be 35 as well. So just without any medications. So we're adding cost. Some people would just say कि आप कोई elderly है, कोई आपको risk है, comorbids हैं, उसमें आप अपना एक special case बना सकते हैं. But as a rule, generally, we don't admit patients, and I've not done it for 20 years. So that's how my practice is. Patient comes like an outpatient, he's treated like an outpatient, he goes home like an outpatient. Same applies to Khalid's unit. They come, they go, they have their procedures, they go to the recovery which I showed you, they stay there, they stabilize. Once they are okay, a few hours, then they go home. They are told to report in case they have any, obviously if they have any pain or they have black stools, they come back, period. But what is the risk of bleeding? We discussed, it should be very rare. So you'll admit 2,000 patients to save one patient. You know, so इसलिए इसको नहीं करते.
Because we've got a rural sort of a population as well, जो कि periphery में गाँव में रहते हैं. तो उनके साथ हमारा ये होता है कि वी सिलेक्ट द डे केसेस, उसका ये होता है कि दे शुड बी विद इन 30 मिनट्स ड्राइव ऑफ द हॉस्पिटल, बाद नहीं होते, तो उस केस में इफ दे आर लिविंग ऑन देयर ओन, in that case we keep them overnight after. Otherwise all our ERCPs, everything is day case.
You've seen 25 cases in the last 3 days, okay? Except for the one that had problems. None of them would be admitted just because of the procedure. If they're already admitted patients, that's different. Correct, Sajda? Right? So that's post-op care. I think we are ready for the cleaning thing. Quickly, Akram, kahin bula lein. And you have to go. Yeah, you see, but the important thing here, you must remember, is this damn thing called elevator.